have you here with us on the Stronger Marriage webinar produced by the Utah Marriage Commission, hosted by the Utah State University. I'm Alexis Alcott. I'm the UMC Interim Coordinator, and today we're so excited to be joined by DJ Zolman, who is our therapist for today. DJ graduated from USU in 2016 with his master's in marriage and family therapy. He has an extensive background in working with relational dynamics to help people heal through life's difficulties. He loves working in a medical setting where he's able to reach a larger population and uses his experience to help those that speak Spanish and English. He has training in several evidence-based experiences and approaches to help marry the medical and behavioral aspects of health to improve the overall outcome of patients' desires. When DJ's not working, he can often be found working on his homestead, complete with 16 chickens, 8 goats, and 14 fruit trees, or on the local hiking trail with his wife, 2 sons, and dogs, Aggie and Indy. Today, DJ will be explaining integrated behavioral health and how community health centers are changing the stigma of mental health. If you have any questions, please ask them by entering your questions through the Q&A function. The chat will be turned off, so this is the best place to ask DJ any questions you might have during the webinar. We'll have a 15-minute Q&A at the end of DJ's presentation. So then we'll go through all the questions you guys enter, and he'll be able to answer them then. If you have joined us for the CEU credit, make sure to email the Utah Marriage Commission to receive your survey on this webinar. Once the survey is completed, you will obtain an email with your CEU credit certification. We'll now turn the time over to DJ for his presentation.
Thank you, Alexis. I appreciate it. Hi, everyone. It is good to be here. You see, I'm a therapist, and as a therapist, what we do is we listen. And so as I was preparing for this, we'll see how well I can talk for the next 45 minutes. We're about to find out, aren't we? Well, I'm going to go ahead and screen share, and we're going to go get this slideshow taken care of. So as Alexis had mentioned, I'm going to be talking about the positive effects of integrated behavioral health for couples. Now, not only is it for couples, but just for the population in general, just because we can see that there's a growing need of mental health concerns that need to be addressed in a timely manner. Before we get to that, though, I want to introduce a little bit of what Alexis had mentioned. So in this picture, you'll see goat yoga. This is my 3-year-old son, Theodore, and on his back is one of our 6-week-old goats named Hemingway. And then you can see us for Christmas, having a lot of fun. You got to do matching pajamas, right? That's what Christmas is all about. And then there's my beautiful wife with our other new baby goat, Ernest, and then our 10-month-old Graham, and then me and my boys. This was a trip that we went to just in November for Thanksgiving in Hawaii. Truthfully, the reason I do what I do is for these people right here. I would not be the therapist that I am today if I didn't have their loving support. And truthfully, this is what I love being able to go home to. I live on an acre in Hurricane, Utah, and we love living the homestead life. So it is a lot of fun. Goat yoga, we actually really do goat yoga. So you guys will have to come down and practice with our goats. What I want to do today is talk about what is IBH, integrated behavioral health. How does integrated behavioral health impact couples? And third, how is integrated behavioral health effective? And then we'll also go over the summary and some questions at the end. So what is integrated behavioral health? A simple way to explain it is integrated behavioral health is the combined effort of medical and behavioral providers that focus on the entire patient when it comes to their care and making their life better. It includes charting in the same electronic health record, having fluid communication with other care team members, and allowing the patient to visit with both providers, meaning both behavioral and medical, on the same day if needed. Integrated behavioral health focuses on blending high-quality care and adding value to each visit, focusing on the whole individual. Behavioral health consultants, otherwise known as BHCs, at Family Healthcare, which is where I work full-time, play a different role than in traditional mental health therapists. Integrated behavioral health is a medical model that asserts the importance of addressing the mental, emotional, and behavioral health aspects of a patient's health in conjunction with their medical needs. Being able to address both behavioral health and medical in the same visit is not only beneficial to the patient's time and finances, but by combining both services, we are sending a long-term message that behavioral health and medical services are inseparable. You can't separate the mind from the body, nor the body from the mind. What we do to family healthcare is not only crucial, but essential to all patients. The way I think about it is often it's we marry those two worlds together. I think often what we in the outside world, you say, yeah, if you need to go visit with your therapist, go ahead. But if you need to go visit with your medical doctor, go ahead. But the conversation between the two isn't very fluid. What we really try to do is we really try to combine our forces all in the same. So at Family Healthcare, we have 14 medical providers, DOs, MDs, family nurse practitioners, and physician assistants. And then we have 7 different types of mental health clinicians, hoping to hire an 8th anytime. And that ranges from licensed marriage and family therapist, associate MFTs, clinical mental health counselors, LCSWs, and clinical social workers. So it's a lot of fun to kind of have a broad array of mental health disciplines all doing the same type of work in a medical setting. None of us behavioral health clinicians ever received any of this training in graduate school. It's something that is so new in our communities that a lot of the training is hands-on. So behavioral health consultants work alongside medical providers in real time. We are often called into exam rooms to work with members in what is called a warm handoff. This is where the patient sees the physician first and then sees the behavioral health consultant, or vice versa. BHCs provide support for mental health concerns such as depression, anxiety, substance use disorders, ADHD, bipolar disorder, among all other diagnoses that you would find in the DSM. We also will address physical health concerns such as management of diabetes, chronic pain, hypertension, or sleep issues, just to name a few. A central goal of integrated behavioral health model is to improve access to behavioral health care while supporting the interventions of the medical care team. The BHC works as a primary care team member. The core of the IBH clinical approach is team-based care that provides care management and supports individuals in their health goals, be that medical or behavioral. Working closely with primary care providers, the BHC delivers brief evidence-based services to patients in the IBH model. So when we talk about combining forces, we really are looking at how we can both utilize the expertise and have that impact the patient. What makes it so fun is that I am sitting shoulder to shoulder with these medical providers. There's not their office and my office. We actually don't even have offices. We are literally sitting next to each other. My desk is right next to the medical providers, and we're talking about all of the patients that are coming in that day to decide who needs behavioral health support. I want to review our team. So first and foremost, we have our CEO, Lori Wright. She is a fantastic visionary on what the future of integrated behavioral health looks like. She can see the end before the rest of us can. I joined Family Healthcare in 2017. In fact, I had started after I graduated from USU in a small private practice, and I loved that private practice. It was a lot of fun. At the time, I was only visiting with children, and as much as I love children, I realized I speak Spanish, I'm not using it, and I have a whole other skill set that I'd like to use other than just with children. So the opportunity arose for me to join Family Healthcare, and I took it, and I've been there ever since. When I started at Family Healthcare, I was one of 2 behavioral health clinicians. And now you see here that there are 7 of us, and we are hiring an 8th. With me being the director of behavioral health, it's something that I was kind of worked up to. So when it was just 2 of us, we were kind of just figuring it out, getting our feet wet in what integrated behavioral health looked like. And kind of what we were doing is we were leaning on experts across the country. In the state of Utah, we didn't have a ton of resources. And so we were reaching out to people back east that had been doing it for decades longer than we had. In that time frame, of course, we've done trainings every year, sometimes quarterly, that really kind of help us buy into the integrated behavioral health model. So these are the people that are doing a lot of the numbers that I'm going to be sharing with you later today. So we have Dr. Adam Monk, Kinsey Tolman, Talasia Bracken, Galia Serrato, Steve Murdoch, and Lorraine Murdoch. And it's Dr. Steve Murdoch. So it is great. We have 2 PhD clinicians on our staff. And you can see we have a variety of CSWs, LCSWs, and MFTs. So it's and 1 CMHC. So that the 7 of us together will do all of the integrated behavioral health visits. And I'll show some numbers here in a moment. Okay, so these are the family healthcare behavioral health patients. Year by year, you can see in 2017 and 2018, when I was joining family healthcare, we were only visiting with 1,000 to 1,200 patients per year. Now that's exclusively behavioral health. You can see that we trailed a little bit in 2019, and then we had a huge bump. We were able to hire 3 additional staff members in 2020, and then even more in 2021. And you can see that average growth year over year is almost 50%. The need is there. The need is definitely there. So it's a lot of fun to be able to work side by side with these medical providers to say, hey, how can we help the patients that need this care? Now, these are just behavioral health patients. This isn't counting the 13,000, I want to say upwards of 15,000 patients that come in for medical reasons exclusively. But of those, obviously, we are stepping in and visiting with a lot more people than we would be if we were just in our own kind of private practices. Now, these are the family healthcare behavioral health encounters. So what that means is each session is considered an encounter. So same growth year after year. We can see it's a 32, almost 33% average year over year growth. And what our model looks at is what we do is each of those BHCs, we split the 40-hour work week into doing 60% integrated behavioral health and 40% specialty or traditional therapy. So I used the term warm handoff originally when I was introducing integrated behavioral health. What a warm handoff is when the medical provider is visiting with the patient and discover some type of need that I can help address as a behavioral health clinician. So what's going to happen is that's a warm handoff. Well, where the medical provider is introducing me to say, hey, I'd like you to visit with DJ. He's got some expertise in X, Y, and Z. And then I will kind of visit with that patient. Typically, it's at the very same time. That's what makes integrated behavioral health so effective, is it's not having to reschedule with me at a later date. It is, let's visit right now. You're here. And the best part about it is there's no additional cost to the patient. It really is amazing to say, you know what, I went and I visited my medical provider today. They spent 15 minutes with me addressing X, Y, and Z need. And I also spoke with a mental health therapist, and they also spent 15 minutes with me. So it was a 30-minute visit. I was there for 45 minutes. Talk about value for that time spent in that clinic. If I were to decide with that patient, for example, that maybe there was some trauma symptoms that needed a little bit more help, I would then pull them into what we would call one of our specialty sessions, where I'm going to be spending more upwards of 30 to 45 minutes with the patient to address some deeper concerns that obviously are not going to be addressed in a clinical setting. Our motto is making lives better in Southwest Utah by providing access to quality healthcare, regardless of financial, language, and cultural barriers. I would add one of the things that makes our work so fantastic is so many members of our team are bilingual. So we really do have a large Hispanic population that doesn't know where to go for medical services. And so we're able to kind of help treat them here as well. And then, of course, also the people that are insured. We recognize that there has to be a variety of payer mix, we call it, where there are some people that are paying cash and other people that have insurance. And that's how we can kind of treat people the effectively way that we do. What I want to do is, let's see. I want to talk about how how integrated behavioral health is impacting couples. So we have a data analyst who helped pull these numbers, and of all the people that received visits in our clinic last year, 60 of them were couples. What that looks like is that 16 of these couples had their first therapy session integrated with medical services. Just using that warm handoff scenario that I just talked about, that is fantastic. So kind of what that looks like is maybe a patient is coming in and they bring their significant other, and they decide, hey, we've got some symptoms of anxiety or depression or even some chronic pain. Well, let's talk about how it's negatively impacting your relationship. And then what we do is that first therapy session becomes integrated behavioral health. And then 6 couples had their first therapy session within a week after the medical services. And then the rest might have been over 2 weeks or something along those lines. But the highlight here is that patients that might not otherwise seek couples therapy, who would need it, are receiving it. So let me explain a couple of stories of what this looks like. And these are personal because I, as an LMFT, I love working with relationships. So I was invited to do a warm handoff for an individual patient who was coming into the clinic due to a recent panic attacks. They didn't know why. They were just like, yeah, they just really started. They happen a couple times a week, and they weren't sure where it was coming from. So the medical provider said, well, we're not sure why. Let's have DJ come in and see if we can figure out what's going on a little bit more. So I step in, and after several questions, it was discovered that the symptoms of anxiety started after an affair was exposed. Guess where that couple ended up? If you said divorce court, you are wrong. They ended up with me, and now they're doing so much better. So in a situation like that, this partner was being there to kind of be supportive in the medical realm, just because it is such a unique world to explore. And so the ability to kind of come in and say, oh, actually, we got some couple stuff going on. How has this affair and these panic attacks impacted your relationship, and how can we help navigate that, in addition to maybe medication that your medical provider is helping you work through? Another story I want to share is that a patient had been working with his primary care provider for quite a while due to depression and some ADHD symptoms. Just couldn't find the balance. He's so depressed, hard to get out of bed. Also had some ADHD where he's like, I just get so distracted. I get depressed for a minute. It overwhelms me. And then I have these symptoms of ADHD. I just can't focus. He had gone through a divorce a few years prior and was not happy in his living situation. Again, a warm handoff. The medical provider said, hey, DJ, will you come visit with this guy? This is kind of what's going on. And then we went in together. What ended up happening is we did some depression work, and then taught some good skills for ADHD. And with time, he and his ex decided to start dating again. So they began to, quote unquote, do it right this time, is what they said they wanted to do. And they began coming as couples. And they have done so consistently for several months. And actually, we're just engaged on Christmas. So I would definitely count that as a major success from the individual that was in my office, so many years ago, just in the super negative depression state, didn't really kind of know what he wanted in his life, and some symptoms of ADHD that were all consuming. So definitely exciting to see that one. We do a lot of trauma screening. We've been trained in trauma-informed care. And so we try to be really, I hesitate to use the word hypervigilant, but we really are extremely vigilant on how maybe what we're doing might be triggering somebody's traumatic response. And so in that realm, we are trying to also navigate the difficulty of people that are coming in for trauma and are looking for trauma reduction skills. There was a female patient that I was introduced to who had pretty severe suicidal ideation. She had just this really negative self-image where she never really saw herself the way that other people did. And so as we were kind of able to do some specific questionnaires regarding trauma, it was divulged some negative impactful things that have happened to her. So what we ended up doing is processing those traumatic events, which helped increase her self-image, and she started to date during those individual sessions. Well, as she started to date, the idea was thrown out there, hey, why don't you bring in your partner? Let's figure out how we can kind of help the two of you navigate these triggers to the point where we're helping the relationship as well. As you can imagine, they came in and he was also a patient who had been visiting with another clinician because he had some negative trauma experiences as well. So it was kind of fun we didn't ever do co-therapy, but it was fun to kind of help each of them individually. And then as they started to date, definitely focused on that relational aspect and how beneficial it was for them. So now here we are a couple years later, and they have 3 children under the age of 4 and are doing incredibly well from when we first met them. And they were just 2 individuals trying to navigate all of these negative impacts of trauma. And then the last case example, I guess you could say, that I will share is an individual who was coming in. He was a male patient, and he was struggling with his sexuality. He had been raised in a very religious home, and homosexuality was it was twofold. It was the religious perspective as well as the Hispanic perspective. And so homosexuality was like, no, it's not right. And so this individual was coming to see me individually to kind of help him process through a lot of these negative counteracting thoughts that he had about his worth as an individual. We had some great progress. We're able to kind of help him kind of differentiate between, okay, what is the religious piece? What is my heritage piece? And how do I want to use both of those to kind of help me be who I want to become? And then I didn't see him for a while, and I realized he had moved up to Salt Lake. And so I kind of thought that was that. Well, 2 years later, I see his name on my schedule again. And I'm like, could it be he shows up with his boyfriend? And so it was really cool to kind of see that full circle, really struggling with his sexuality, to now kind of allowing him to embrace it and say, hey, this is part of me, this is who I am, and finding that ability to kind of be himself in this relationship. So now that here we are, that was I want to say 1.5 years, 2 years ago, and now they've been married for almost a year and are just blossoming, doing really, really well. And when they had their wedding reception, which they had 6 months after their ceremony, his parents showed up to that celebration, which was a huge thing for him because they were so against his identity. So very, very cool to kind of see how it might start with an individual, but the more that the relationship is built, you can see that were it not for a medical setting where there was some type of psychosomatic complaint or mental health complaint, that a BHC never would have been able to address these patient lives. So part of the effectiveness behind integrated behavioral health is that what we do is there's never a cap. I've never used the word caseload because we never have a cap of number of visits or people that we can see. So yeah, it might be difficult to see somebody weekly. And in fact, if they do need weekly support, we try to help them get that support out in the community. But essentially what happens is the BHC is going to see a patient in the exam room. It obviously the patient becomes into our patient pool. And then what we'll try to do is say, hey, you need a little bit more support here. I want to bring you in to have some brief sessions. Maybe we'll call it specialty therapy. 8 to 12 sessions is kind of what we try to hover around. And then after that, then we'll put them back into the patient pool where we can follow up with them in integrated visits for the life of the patient. It is very exciting to see when I meet somebody. It's not like, okay, let's do what we can for 6 months and then you'll be on your way. And then when you call back, I'll have to put you on another waiting list. It's like, hey, guess what? Anytime you come see your medical provider, I'm going to come in and we're going to touch base and just check on how things were going. What I really loved about the pandemic Can I say that I love something about the pandemic? What I loved about it is that everybody wanted to talk to a mental health clinician because we were all so stressed. And guess what? At Family Healthcare, we could. Absolutely. I'll see you. When's your next appointment with your medical provider? I'll step in. Let's get that taken care of. And so it's been really cool to kind of watch the benefits of that as more and more lives have been touched, as I previously shared in those data slides about how many patients we've been able to touch through our different encounters. So this is just kind of our model that we kind of use to say, hey, once they're a patient, they're always a patient. We really want to focus on engaging with them as much as we can. If they have a specific complaint, that's psychosomatic or even psychiatric in nature, we do also have a psychiatric mental health nurse practitioner on our staff, which she does a lot of what we call psychiatric integrated behavioral health visits. So it's integrated behavioral health, but with her instead of one of us, in addition to one of us BHCs, which really kind of brings in this team approach of having the medical provider, we have the psychiatric mental health nurse practitioner, and then we have a behavioral health consultant. So we have the team approach visiting with the patient in the same visit, totally adding value. And there's not this, well, my doctor said this, my psychiatrist said this, my therapist said this. It's like, guess what? We are all on the same page. And it has been really fantastic to impact people's lives in that direction. Let's go over some figures in 2022. So the PHQ-2 is just the 2 questions that are derived from the PHQ-9. And if there's ever a positive screen on the PHQ-2, we will automatically do a PHQ-9. It just automatically triggers it in the system. So in 2022, we did 38,000 PHQ-2 screenings. And of those screenings, we ended up doing 12,799 patients or having a BHC go in to visit with that many because of their score on the PHQ-9. Now, in the middle of the page, this is something I really want to highlight. So the average PHQ-9 score reduction for patients that had a PHQ-9 score of 9 or above, there was only a 7.6 reduction if they only ever saw their medical provider. But if they saw their medical provider and a BHC, there was a reduction of 37.2%. I mean, that is reason enough to do integrated behavioral health, right? Because at that point, what you're doing is you're saying your mental health matters. And we really want to make sure that we can do our best to treat you as an individual right here today. Of course, we have the importance of the GAD-7, which assesses for anxiety, and that is what that one is. What I want to do is I want to, 31,000. Okay, so our behavioral health providers are often utilized in follow-up encounters for, it's called UDS. It's just kind of a adult depression screening clinical measure that helps us improve our quality. Since 2020, patients who have scored a PHQ-9 score of 9 or greater received a reduction of an average of 7.6 on their score, just meeting with the medical providers, as mentioned. When these patients met their behavioral health providers, they received an average reduction of 10.5 points on their PHQ-9 score. That takes it from severe depression to mild. That's huge. Just kind of echoes the benefit of doing integrated behavioral health. Now I want to talk a little bit more specifically about some certain diagnoses and the benefits of doing integrated behavioral health with these diagnoses. So let's first talk about, we just talked about depression, so now we're going to go to the anxiety. So you saw how many screenings we're doing. This isn't as often, but often it goes side by side with the PHQ-9 and a depression diagnosis. So with anxiety, starting in 2020, so Family Healthcare has completed 588, 997, and 1,120 anxiety screenings using the GAD-7 in 2020, 2021, and 2022, respectively. 588 the first year, 997, and now 1,100. With the follow-up screenings we've done since 2020, patients who have scored 10 or higher on the GAD-7 scale experience an average decrease of 3.5, which translates to a reduction of 19.7%. These screenings are completed by both medical and behavioral health providers. However, Patients who receive anxiety screening have an average of 3.3 encounters, which means sessions, with a behavioral health provider, regardless of their score. So guess what? You come in and your medical provider diagnoses you with anxiety, you're going to visit with a BHC. You have a therapist in the community, great. We want to make sure you keep that therapist in the community. But anytime you come to your medical provider, you're also going to be visiting with a behavioral health consultant, because we want to enforce the idea that you can't treat the mind without treating the body, and vice versa. We marry those two together. In 2021, now let's move to trauma. In 2021, our behavioral health providers began using the Adverse Childhood Experience screen, with a total of 1,114 patients have received. The ACE screenings help us capture and better understand the genesis of the variety of mental and physical health issues of adults in a campaign to help reduce childhood trauma. During the same time period, behavioral health providers have administered 284 trauma screenings with children. What we're doing as we use these ACEs is we are utilizing trauma-focused cognitive behavioral therapy and PCIT, or parent-child interaction therapy, which are the two of the best models of therapy to help children who have lived through a traumatic experience of some kind. From a personal example, I did PCIT with a caregiver, and the first 5 sessions, part of what you do in PCIT is you say, okay, these are the toys you're going to play with. I'm going to be in a different room. I'm going to be observing for 5 minutes, and then I'm going to coach for 15 to 20. So what had happened is I'm observing for 5 minutes, and this kiddo is dumping out all the toys, walking on them, throwing them, and dad is doing a great job reflecting everything that's happening. But after that 5-minute mark, I said, are you okay with your child throwing, stepping, and breaking toys? Of course, the answer was no. So I said, I want you to start ignoring the minor misbehaviors, and I want you to focus on the first positive thing that you see them do afterwards. So in that 15-minute time frame, I was able to really coach this parent who was then helping the child. And by the end, there was no stepping on toys, there was no breaking toys, and there was no throwing toys. The father looked at me and was like, I cannot believe how well that just worked. And so it was really exciting to kind of have that perspective to say, guess what? This father now is going to go back home and utilize these same skills because he can see the benefit of doing so. Honestly, I do very little play therapy anymore because I believe in helping empower the parents to be that therapist to change it in the home long term. So really exciting to kind of assess for the trauma and say, not only are we assessing, but we know how to treat. And so we're going to do both. Now, I want to talk a little bit about hypertension and diabetes. These are two, obviously, medical conditions that are like, well, why is a BHC talking about medical conditions? And the truth of the matter is that, yeah, they're married. You can't separate the mind from the body. And so hypertension is obviously blood pressure. And so what happens when a patient comes in and they keep having elevated blood pressure, we realize, okay, well, what's causing you stress? Are you stressed because of the pandemic? Are you stressed because of what we joke is called white coat syndrome, because you're in a doctor's office and sometimes it's intimidating? And so what we are able to do as a BHC is when the provider says, hey, they've had 3 readings that are all pretty severe, would you go in and kind of help them calm down a little bit? You bet ya. So a BHC is going to go in, we're going to say, okay, you got a diagnosis of hypertension. Why is a BHC in here? Don't worry, I'm only going to spend 15 minutes or so with you. Let's see how we can help bring that down. We'll focus on some skills to help kind of calm their breathing, do some belly breathing techniques, which is probably one of my favorite. In fact, I'm going to do this. I'm going to explain it to you so that we can do it together. So for those of you that are watching, I want you to take your right hand and I want you to put it on your belly. And I want you to take your left hand and put it on your chest. Without changing your breath, bring your awareness to which hand is moving more as you breathe. My favorite is when I do this with 2 people in a room and they have different answers. One of them will say, oh, I can feel it in my chest. And the other person says, well, I can feel it in my belly. Now, this is a TFCBT skill, and it's called belly breathing. So a patient comes in, they've got hypertension. I'll say, we're going to do some belly breathing. I'll say, okay, now if you feel comfortable, I'm going to have you close your eyes. And I want you to bring your attention to your breath. And as you bring your attention to your breath, I want you to focus on keeping your hand on your chest still and the hand on your stomach. I want you to focus on moving that in and out as you breathe. Breathing in through your nose and out through your belly. Out through your mouth. Focusing on moving your belly as you inhale and exhale. Breathing in again. And an exhale. And again. Them how they feel after. My favorite is when they notice it in the chest at the initial question, they're always able to say, oh yeah, I feel more calm when I breathe from my belly. I'll say, chances are you have an elevated blood pressure because you're not breathing from your belly. Well, of course, there's also some medical concerns, but that's what the BHC is within scope of doing. I can't change the medicine. That's what your medical doctor is going to do, but I can help you with skills that's going to decrease your blood pressure, right? And so it's kind of just saying, okay, let's practice this several times throughout the day so that we can find better ways of breathing so that your health is not negatively impacted. So that's been a lot of fun to use these skills with patients who are hypertensive. That guess what? They're going to say, no, I don't need to see a therapist. Well, guess what? You just did, which is why it's kind of fun to say, yeah, you'd never come see me if I had my own private practice, but here we are visiting together, and it's helpful. So really cool to do that with hypertension. And then diabetes. So diabetes is one that I knew very little about before joining the team at Family Healthcare. And diabetes is obviously where your pancreas is not producing insulin, or it's either not producing it or is not filtering it. And so you have high blood sugars. So with these patients with high blood sugars, obviously it's stressful because it's a chronic condition. Depending on the level of diabetes that you have, you either have to give yourself insulin shots, or you're taking several different types of medication. And it's just overwhelming. It's very overwhelming. You have to watch what you eat. You have to it's one of those things that causes a lot of distress for people. And so we received a grant that kind of helped us focus on these patients with diabetes. And we have been able to serve almost 250 patients who meet regularly with their behavioral health providers and their medical doctor. So it merges the diabetic care with medical and behavioral health care. And these diabetic patients typically experience a 17% decrease in their A1C volatility after joining the program. Since diabetic behavior is chaotic in nature, averages and medians do not illustrate this population well. So what we've done is here we have a before, you'll see a before UPIVIC. That's just the name of the grant that was received. You can see that the average A1C was 9. So 45.3% of the A1C results were in the first 2 quintiles, which definitely shows. Who would have thought I'd ever be talking about statistics? I hated statistics in graduate school. Yeah, here I am. And I'm so thankful because it makes sense to me. Okay, so almost 50% is in the first 2 quintiles, which shows, okay, our A1Cs are too high as a system. And so creating this histogram of the A1C results of these patients before they start the program. And then on the right, you'll see after the program, which gives us 61.8%, which shows that there's been a dramatic reduction in their A1C. And to clarify what an A1C it is your 3-month snapshot of your blood sugars. So people get a finger prick and it checks their blood sugar day of, but the A1C checks the last 3 months. And so it's been really cool to kind of watch these A1Cs decrease. And we know that those that saw a BHC and a medical provider are this group because they were able to kind of visit with us more often. They're able to implement some of the practices that we discussed. And it wasn't just monitoring the medication, but really a behavioral shift as well. So it's been really exciting to work in family healthcare, and one of the best things I love about it is being able to kind of integrate behavioral health into a medical clinic. The benefits of it, of course, far outweigh the issues, recognizing that yes, there are individuals that are being supported and couples. I love the relational aspect of it. And so just the relationship between the mind and the body to me seems so natural. And so being able to kind of merge those two really has been quite rewarding. And then the effectiveness of it, we're visiting with more patients that typically wouldn't see it. And this isn't a statistic that I included here, but I remember hearing that over 80% of patients who have died by suicide saw their medical provider within the previous month. I need to verify where I saw that information, but I was blown away. And I'm like, that is reason enough for me to stay working in a medical clinic, because I can help jump in as often as possible for some of these patients. So that's the summary. Thank you for joining us. If you want to reach me, here's my email, my phone number. Family healthcare, of course, we're always looking to expand our team. So if you are, or anybody you know is interested in kind of switching your career paths up a little bit, give me a holler and we can see what we can do.
Thank you so much, DJ. Now, if anyone would like to just ask their own personal questions about DJ's presentation or about his career or whatever, please put those questions in the Q&A function and he'll go ahead and answer those. While we're waiting for some questions though, I was wondering, what are some IBH strategies that we can utilize at home outside of therapy?
So the belly breathing technique is probably one that I use every single day, just because the idea of putting your hands on your chest and your belly kind of triggers just the other side of the brain. That was one of my favorite things that I learned doing the TFCBT training. And so that's one that I will often say to utilize. Another technique that I often will use is just kind of tapping. So as we do the tapping with EMDR, it's super common. Sometimes what I'll do is I'll just say, hey, whenever you're feeling distressed, just start to tap your fingers for a second. Okay, you let this become a little bit of a trigger to kind of help you decrease the stresses that you're facing, but to keep you also in the present moment, right? We're going to do some tapping and we're going to follow our breath with it, and see how that is able to positively impact you at home. Okay, great question, Melissa Child. How is the expense of the service covered? Insurance, private pay? I'm guessing the patient has to consent to therapy. For sure. So I can think of one patient off the top of my head who asked me to leave once I told them what I was doing. Not what I was doing. Here's my spiel. I say, hey, my name is DJ Zolman. I'm a licensed marriage and family therapist. My title, that's my license, but here I'm a behavioral health consultant. What I do is I just supplement the work that your medical provider is doing. He or she does everything medical. I do everything behavioral. What I want to do is I want to spend 15 to 20 minutes with you to kind of discuss X, Y, and Z and how it can help that. So by them coming in, they're consenting. But then, of course, if we have them say, hey, let's do some more in-depth therapy, then, of course, they're consenting to that as well. So when they're coming in, they're going to pay their copay to see their medical provider. And then there's no cost for the BHC to go into that room. Now, the insurance, yes, if they do have insurance, we're going to bill insurance. And if insurance doesn't cover it, then, of course, we slide that off so that payment never goes, or that bill never goes to the patient. So if it's private pay, guess what? It's to your advantage to come see us both at the same day, because you only have to pay once to see both of us. But if you're just going to come see me, then of course there's going to be a cost for that. So I hope that answers your question, Melissa. If not, let me know. Hope that was sufficient enough of an answer. It's been fun, and truthfully, we were worried about the insurance reimbursement initially, but we've been able to have some great conversations with different insurance providers and boards and the legislature to kind of push for more reimbursement. And so there are several insurance agencies that will reimburse both the medical visit and the behavioral health visit when it's done on the same day. As more questions are coming in, one of the things that's been fun about working at Family Healthcare is where I'm at today. I never would have expected this is where I would be when I graduated. So it's kind of fun to just kind of watch things as they develop. I'm also on the board of the Utah Association for Marriage and Family Therapy. So it's kind of been fun to use that as an avenue to say, hey, really, let's really join forces to see how we can get this into more healthcare agencies across the state. Thank you, Shayri. I'm glad you have enjoyed this presentation. A CMHC student, very cool. Yeah, it's definitely a unique model. An anonymous attendee, thank you. Glad you've enjoyed it.
While we're waiting for some questions, how did this model kind of originate, or do you know, DJ?
You know, that's a good question. I don't really know how it originated. I'm sure just people would realize, hey, we've got to work side by side. We've got to be working in closer proximity. Oftentimes clinics will have a co-located where it's like, come to one building and we'll be in the same building, but different sides of the building. Realize that's still not close enough. Because they're charting in their own different formats. You know, maybe one person's using Simple Practice and somebody else is using ECW or Epic or some type of electronic health record. It's like, let's just use the same electronic health record, because even if I see somebody in a specialty session and I don't have a chance to talk with their medical provider, that medical provider can read my note at their next visit. And that's part of the consent that's so important that everybody's agreeing to when they sign up to become a patient. There are some clinics on the East Coast that have been doing this for 40 years. And so they've been super beneficial in just coordinating and doing some additional trainings to figure out how we can make this work for us in our clinic. Melissa, we are located in St. George, Utah. It's a clinic. It's called Family Healthcare. It's a community health center. Other health centers do this across the state, but honestly, in all the trainings that I've been to across the state, they are not nearly as advanced as we are. So I don't know. I don't want to like toot my own horn, but it is really exciting to say like we're on the cutting edge of really integrating our services side by side. So if you want to come work with us, come on down. Sherry Chipman says, what about patients who don't have insurance coverage for behavioral health, but need therapy versus the medical appointments? So this is what I love about working at, it's called a federally qualified health center, is that we have a sliding scale. And so even if a patient doesn't have insurance, what we'll do is we'll bring them in and say, okay, what is your household annual income and how many people are in your home? And based on that, it'll give us a percentage of poverty. And based on that percentage of poverty level, they will pay a certain fee. So I think currently our lowest fee is $30 per session, and it can go up to like 173. If they're going to pay 173, I'm like, okay, yeah, you could pay us for that. But there's also a lot of people in the community that aren't going to charge as much if you're on our highest sliding fee scale. But that's definitely an option that people can choose to do if they want. If they don't have insurance or they need help getting on insurance, it's kind of how we help approach that whole person. We also have people that help you get on insurance. So we have what are called navigators, and they're like, hey, yeah, you have any insurance questions, come on over, and we'll see how we can help you get a good insurance that fits your needs. Great question, Sherry. Carrie Boone says, I love the incorporation of ACEs screenings. Have you seen this impact the understanding of medical conditions with knowledge of trauma added? How do you screen? Carrie, fantastic question. Yeah, so there's a book that's called The Deepest Well, and it's by Dr. Nadine Burke Harris, and she's the former Surgeon General in the state of California. And I love her. She's like, I love her because she understands the ACEs in a way that says we have to do something now about it. So I absolutely think people understand. Oh, good, you've read it. Yay. Yeah, I think a lot of people are starting to understand why it's so important that we screen. And we're not just going to screen and say, okay, we'll send you on your way. Like, no. If we're going to screen, we're going to talk about it. You might not want to, and that's okay. But when you are ready, we're going to talk about it. So how we screen is, truthfully, I'm not going to screen in an integrated visit because I'm not going to have enough time to approach it. And so I save that screening for when they're coming in to see me for what we call a specialty session. And on that first specialty session, after I've already met them in an integrated setting, then I'm going to ask them those ACE questions. And it's just part of my assessment. I give them the PHQ-9, the GAD-7, the MDQ, then we'll do the ACE, and then I have a whole list of other questions that I really want to make it a good Q&A visit, but also make a concrete diagnosis and then go from there with our treatment plan. So great question, Carrie. Sherry, why doesn't everyone do this? Great question. A great question. I love this model, and I know that there are a lot of other health centers in the state that are trying to do it, but none of them have as many behaviorists to medical providers ratio as we do down here in St. George. So great question. I wish more people would do it. We're working on it, though. We're definitely working on doing more training throughout the state. In fact, I have breakfast with the legislature in a week and a half to kind of help say, hey, can we get some more funding for the state to help more clinics do integrated behavioral health?
What would be your hope to be able to integrate that throughout the state in this meeting? If you could pick any vision in the next 5 years for this model, what would that be?
Honestly, my vision for this model is that every community health center has more mental health support. Because yes, I understand the how lucrative private practice is, but what I love about what I do is I'm reaching out to people that would never either A, be able to afford the private practice clinician, or B, would never go because of the stigma. But guess what? They're seeing me in a doctor's office. It's way easier to say, oh yeah, I've got a doctor's visit. Great, fantastic. Then let's help break that stigma. So my 5-year goal would definitely be to say, let's get more BHCs in community health centers across the state. Let's train them, let's help them, and let's help our community at large.
Well, awesome. Thank you so much for joining us today, DJ. And thanks everyone else that's participated and done questions and been able to be here with us today at this webinar. We're so grateful for your participation and we're so grateful for you, DJ, as well. This really was amazing. I second Carrie Boone and everyone else has been saying this was so good.
Thank you. It's been a pleasure to be here.
Thank you for us too. Once again, if you did attend this webinar for the CEU credit, make sure to email into the UMC email for your survey as soon as possible. Once you finish that survey, we'll get you a certification email back to you so that you can get that CEU credit. And thanks everyone for joining us. We hope that you have a great rest of your night. Bye, guys.